Hi, I'm Dr. Kim Keebler. I am the editor-in-chief of the Multiple Chronic Conditions Resource Center, and we are very pleased today to announce Dr. Cheryl Phillips as our speaker. Dr. Phillips is the immediate past president and CEO of the Special Needs Plan Alliance, a national leadership association for special needs and Medicare Medicaid plans serving vulnerable adults. Currently, she is a senior program consultant for the John A. Hartford Foundation's Age-Friendly Health Systems Initiative. She has extensive experience in health policy, Medicare Advantage, special needs plans, and the program of all-inclusive care for the elderly, which is also known as the PACE program. As a fellowship-trained geriatrician, her clinical practice is focused on the long-term care continuum. Dr. Phillips is a past president of the American Geriatric Society and also a past president of the American Medical Directors Association, the Society for Post-Acute and Long-Term Care Medicine. She continues to serve on multiple technical advisory groups for chronic care, long-term care quality, home and community-based services, and person-centered measures, and has provided multiple testimonies to the U.S. Congress. She has served as a primary care health policy fellow under Secretary Tommy Thompson, and she is currently appointed to the Veterans Administration's Veterans Affairs Geriatrics and Gerontology Advisory Committee, as well as the Battelle Partnership for Quality Measurements, Pre-Rulemaking Measure Review Committee for Post-Acute and Long-Term Care. She is very qualified, and we are honored to have her today. And I initially met Dr. Phillips through her presentation with the Agency for Healthcare Policy and Research, Person-Centered Care Planning for Persons with Multiple Chronic Conditions. So thank you, Dr. Phillips.
Well, thank you, Dr. Kubler. And that was a long but delightful introduction. I appreciate all the kind words. But most importantly, I'm excited today to talk about how we're going to improve the care of older adults, particularly those with multiple comorbid conditions and complex care needs. So I'm excited to be here. Thank you.
And we're happy to have you and know that your expertise is very valuable. So please help our audience to understand what is meant by the 4 M's and the scope of this concept throughout the U.S. as we begin this podcast.
Oh, I'm delighted to do that. So back in 2016, the John A. Hartford Foundation, in partnership with the Institute for Healthcare Improvement, known as IHI, also the American Hospital Association, AHA, and the Catholic Health Association, pulled together a group of experts and a body of evidence and spent an entire year looking at what is the essential set for equitable, safe, and appropriate care for older adults. Frankly, it applies to all individuals, but focusing on older adults. And they came up with this set called the 4 M's. In many ways, the 4 M's are wondrously simple, but when you think about them, they are the essence of care for older adults. And again, evidence-based, causes no harms, and it's focused most of all with what matters. And we'll talk a little bit more about what matters. I'll mention the 4 M's, but I'll also add that many organizations, particularly academic settings, have added additional M's, including multiple morbidity as a 5th M. And the John A. Hartford Foundation is certainly supportive of all M's. Malnutrition may be an M. There may be other M's, but it's these 4 M's that are the core of what is age-friendly healthcare. It is what matters. That's at the top of the pyramid, because all things are based on focusing on the individual and their family caregiver unit, what matters. Medications, we know that it is essential to understand both the appropriate use and oftentimes the inappropriate use of medications in older adults, particularly when they have polypharmacy, multiple medications that may have interactions. Mentation, including not just dementia screening or memory cognition, not just depression screening or other mental health illnesses. Those are all critically important. But as we think about the persons with serious chronic conditions, particularly in the hospital setting, delirium is an important aspect. And delirium needs to be assessed regularly, whether it's in the ED on presentation, whether it's throughout the hospitalization stay on shifts, because it's often the trigger for a change of condition. And we know that delirium impacts morbidity and mortality for hospitalized older adults. And then the last M is mobility. Mobility is more than just falls prevention. We focused a lot on keeping people in bed so they wouldn't fall, but mobility says, we're going to let you move. We're going to help you move. We're going to focus on, can you sit up? Can you feed yourself? Can you get to a chair? Can we have you ambulate down the hall? Because we know that when people are more mobile, they do better in the hospital. Their mentation is better. They have less risk of delirium. But when you go back to these 4 M's, what matters, medication, mentation, and mobility, now you can see how they all fit in together. So what matters being the core, what are my goals for this hospitalization? More importantly, what are my goals in a broader picture? What matters is so much more than advanced directives. And then how medication impacts mentation, we know that. We know it impacts delirium. We know it impacts short-term confusion. We know that it impacts mobility, but we also know that mobility can impact mentation. So you can see how the 4 M's are not just individual questions, but are a set of focus. There's now a widespread national movement working with the IHI and with AHA on both systems of healthcare delivery, and there's now 30 healthcare systems that are engaged in both a deep and a widespread. It's also exciting to know, and we know that this is an undercount, but there's over 5.5 million older adults that have already been impacted by all 4 M's. And the work continues. This is what's exciting because we're really at a tipping point. So that's a little bit about the history of age-friendly health systems.
And it is exciting to see how it has spread across the country. So in the context of an aging society and the implementation of the 4 M's, how do you see this tie into the concept of person-centered care planning? I know you discussed what matters, and that really is part of person-centered care planning, but how do you see this, all of the 4 M's fitting into this concept?
Thank you. And I see the 4 M's as fundamental to person-centered care planning, because when we think about the care plan, all too often, particularly in the hospital, but even in the outpatient ambulatory setting, we focus on disease states. So they have diabetes, this is our care plan. They have lung disease, this is our care plan. But if we start with the framework, first of all, and again with what matters, but you can do the care plan in the construct of these 4 M's and how each of the interventions planned impact the 4 M's, but also how the individual and sometimes their family and care partners are part of that care planning with understanding not only the disease states, but the interventions as they are framed in the 4 M's, starting with what matters. So to me, it's really foundational for developing a person-centered care plan. And as you mentioned earlier, most of my clinical work was post-acute and long-term care. And in those settings, person-centered care plans are integral to the delivery of care. Again, starting with the 4 M's as the framework for that model, it then informs not just the physician and nurse practitioner, but also the pharmacist, the nurses doing direct care, the therapists that are supporting the person. 4 M's care becomes that foundation for person-centered care planning.
That's perfect. Thank you. So the John A. Hartford Foundation provided a strong presence in the Agency for Healthcare Research and Quality's initiative on person-centered care planning for persons with and at risk for multiple chronic conditions. How will this work continue through your agency, given the administration's changes to ARC?
Well, thank you. And I'll pause a little bit because I think we all share the concerns of what will happen with the important work with the Agency for Healthcare Quality Improvement and Management. We know that changes are coming, but we also know that the core reason for the work, addressing safety and quality, particularly for those with multiple comorbid conditions, continues. So we are hoping that the administration, although there have been significant and unfortunate changes to ARC, we know that the research for the management of individuals with serious chronic conditions needs to go forward, and we hope that it evolves in another frame, if it will, maybe another form, but that the work has to continue because the need from the patient side hasn't gone away just because there have been administrative changes. And we know that failure to address serious complex conditions results in inappropriate use, waste, and excess cost for the healthcare delivery system, which is something that this administration says they are focused on, is to improve efficiency, decrease waste, and decrease cost. So doing so, you have to focus on the research and implementation of safe practice for individuals with complex and comorbid conditions. Putting that aside, the work of the John A. Hartford Foundation is going full bore. And as I mentioned, in the partnership with IHI and the American Hospital Association, we are rolling out the 4Ms in all settings. So the hospitals are critical. So are convenient care clinics. And that has been done work predominantly with CVS and Aetna, but we are also working on ambulatory practices. There is the work that is already being done through the geriatric ED accreditation and the geriatric surgery verification. So through surgery and emergency room access, we're focusing on age-friendly healthcare in the 4Ms. We're also starting to look at primary care practices and specialty practices writ large, some who are associated with large health systems, many who are not. And so there's work to be done across the continuum. Oh, and I can't forget nursing homes and home health as yet another area of critical work for rolling out the 4Ms. So we see this approach to age-friendly healthcare as certainly enhanced by the research work of ARC, but not limited, because we have to make this the standard of care for older adults so that when they present, wherever they present in the healthcare system, they know that they can understand what is age-friendly healthcare, what are the 4Ms, and how can they create an expectation to that. I will add another piece of the work that is going to be very important, and that is our partnership with UCSF and their research center on age-friendly healthcare. This research center is looking at implementation, measuring outcomes of implementation, understanding barriers of implementation, and it's really open to anyone who is interested in learning more about this. There are regular webinars, there are regular communications, there are study groups. So in addition to the research that's done through ARC, we're also looking at other avenues of research. And the last piece that is critically important is the CMS healthcare measure. And the CMS healthcare measure is age-friendly health measures. They are by attestation right now. They are now collecting data and will be reported in 2026, and they're part of the Inpatient Quality Reporting Program, commonly known as pay-for reporting. CMS has a link on how those 5 measures of the CMS age-friendly measure tie to the 4Ms, because they added the 5th one that is designing age-friendly care leaders, recognizing that hospital systems need leadership that motivates and maintains and sustains. And so the alignment of the CMS hospital measure with the 4Ms is now giving added impetus to the hospitals to say, okay, teach us, tell us more. How do we make this work? And I think that the next area of work will be taking CMS measures into other settings of Medicare paid care sites. So things like nursing homes, home health, maybe even physician practices. So more work to be done, but to shortly answer your question, we're very saddened about the changes. I think it's devastating for our country, the changes that are happening with ARC, but the 4M's age-friendly work is moving forward.
Right, and I'm glad that the John A. Hartford Foundation is taking a leadership role in this to try to sustain the momentum that ARC has done in this area of care.
Absolutely. And we know that ARC has done so much more extensive work. So I'm not trying to minimize the impact of the changes in the research area that ARC was focused on, but we do know that with the 4M's and age-friendly care, this work will continue.
Absolutely, yes. So what do patients, families, and caregivers need to know to become empowered in their medical care and management?
That is so key, because if we talk about what matters, part of what matters starts with patients and their family care partners even knowing what's going on and knowing what their choices are and knowing what to expect and knowing how to voice it and how to express it. I'll start with some general concepts and then link to a tool that can be very useful for patients and families. But the general concepts are: think about what your goals are and share them with your families. What are your goals about healthcare? Do you want independence over nursing home care? Do you want medications? Are you medication hesitant? Is going to your daughter's wedding in 6 months the most important thing? You can think through all the personal goals and then start to imagine how your present healthcare and life care fits in with that. And that goes along with your medications and everything. And speaking of medications, when you do communicate with docs, make sure that you know what your medications are, but you also know why you're taking them. And the question is then, do I need to keep taking them? Are they continuing to give me value? And any new medication that's added, making sure that the prescriber knows what you're already on and can know about drug-drug interactions. But a tool that I want to provide folks with is the Institute for Healthcare Improvement, IHI.org, has a patient-centered tool called My Health Checklist. It's a simple booklet. You can fill it out prior to presenting to your primary care physician or specialty physician, or even hospitalizations, for example. But it lets you go through the 4M's from your perspective and then present them and share them with whichever provider and whichever setting you are going to. So it's a wonderful tool. Again, IHI.org and I think / My Health Checklist. But even if you just Google My Health Checklist, you will come up with it. It's free, it's available, it's downloadable. The next part to this is we want to make sure that providers across settings of care are giving people this tool, that they know about this tool. So part of the awareness of age-friendly healthcare in the 4M's needs to come from the army of our healthcare team, whether docs, nurses, social workers, therapists, pharmacists. And each of these entities, we're starting to focus on how do we create a new environment of communication around age-friendly healthcare. And then lastly is what we call the age-friendly health systems ecosystem. So how do we look at communities, public health entities, senior centers, other organizations that can push out communication? So you can see that it's a multi-layered process, but the most important thing is letting individuals know they have options and choice.
Yes, that's really important. And we will make sure that we post some of the resources and links that you have made reference to. Part of what we're doing at the Multiple Chronic Conditions Resource Center is expanding into patient family, instead of focusing so much on the healthcare professional, but giving them credible resources so that they can be empowered and promote their own patient care within the healthcare system. So how do we get the message out to patients, families, caregivers, healthcare professionals, and health policymakers on implementing person-centered care planning for the nation's largest patient population, those who are living with 2 or more chronic conditions?
Well, we're looking at all the leverage points we can. So the CMS hospital measure is a big one for hospitals. I think it'll translate also to physicians and other practitioners that practice in hospital settings. I will give a plug for the American Society for Consulting Pharmacists, ASCP. They are doing enormous work on training pharmacists and patient-facing materials on age-friendly healthcare, particularly how it fits in with their medications. We're also working, as I've already mentioned, with a varieties of settings of care. And this tool of My Health Checklist becomes a vehicle for whether it's nursing homes, home health, ambulatory practices, minute clinics, whatever it may be that is serving that individual with multiple chronic conditions. Having the My Health Checklist can be a starting point of the conversation to elicit what matters, to help them focus on their medications, their mentation, and their mobility. And so it's multi-factored. We think measurement is part of it, and measurement that links to payment is a big part. We're looking for measurement in other settings that will help drive the utilization. And then if all of these settings can then provide these tools and resources to patients and family, it creates a tipping point of knowledge so that people start to expect age-friendly care no matter where they present.
Yeah, and I practice in very rural southeast Georgia, so having resources for patients to have would be so important, because it's not like, having a big hospital or, lots of physicians to help with their care.
Well, the John A. Hartford Foundation is also closely working with the National Rural Health Association. I will put in another idea, and that's some of the GUIDE models, GUIDE, which is a platform for providing care for individuals and their families with dementing illnesses. Many of the GUIDE platforms are now digital, which is directly supporting those in rural settings that may not have the physical access. And that's another angle by where we are working with age-friendly care and dementia and GUIDE programs. So you're right, there are unique challenges with rural settings, but we haven't forgotten those living in rural communities.
Yeah, they have just as many issues as anybody else. Is there anything that we haven't touched on that you think is important to, provide our audience?
I will touch on one thing, and that is gaps in care. So one of the areas that the John A. Hartford Foundation is very interested in exploring, and you mentioned rural. Rural is one of them, but sometimes rural is also identifying people that may be of lower income and so don't have access to services. It may the gaps also may be those of different ethnicities and language. So when we think about any group of people that are often left out of mainstream healthcare, or that have gaps in access of care, that's a particular target where the John A. Hartford Foundation wants to think about how do we measure these gaps and how do we help providers address those gaps of care. So that, again, is ongoing work, but part of the mission of the John A. Hartford Foundation.
Yeah, that's important. I have patients that don't have computers. They don't have internet access. So, I think sometimes we make those assumptions that everybody has that, and everybody understands that. And there's some populations that need it but don't have it. So you're absolutely correct. It was an absolute pleasure to have you. And I'm going to get the links that you mentioned in your discussion so that we can embed them as part of this podcast. John A. Hartford Foundation is doing amazing work. And I agree with you about ARC. It saddens me because they have been such a resource to all of us as, healthcare providers and researchers. But we'll continue the work, and what we would like to do, Dr. Phillips, is also have a connection on our website so that we can direct patients and families and caregivers to the resources that the John A. Hartford Foundation produces for patients and families. I get your emails, and I'm just
We'll help you with any of the links that you need.
That's perfect. Well, thank you so much. We really appreciate your expertise and your passion about doing the right thing for our aging society and patients with multiple chronic conditions.
And Dr. Kubler, thank you, because you're out doing the work and you're doing it in a particular challenging environment. So part of why the John A. Hartford Foundation exists is to support amazing clinicians like you who are making it happen. So thank you.
Well, thank you.